Hello, my name is Michael Titzer. I'm a hematologist-oncologist here in Evansville, Indiana, and I'm here today to talk to you about multiple myeloma. So my interest in hematology and oncology started at a very young age. Basically, I was looking to challenge myself in one way, and I thought this would be a big challenge. As I went through school, I developed an interest in death and dying and that process. And as I saw that feeding into medicine, oncology and hematology seemed to be the right specialty for me. I also had some early experience in my family with hospice care, and that was an influencing factor. But also the fascination of science. Oncology and hematology is constantly changing. There are new drugs, new excitement, and just fascinating science behind the whole field that keeps your interest and keeps you on your toes and trying to stay up to date with the latest research. Multiple myeloma is a cancer. It's a cancer of the plasma cell, which is a type of white blood cell that is typically found in the bone marrow. It's a relatively uncommon cancer. There's about 30,000 cases per year in the United States, and it accounts for about 2% of all cancers. So again, relatively uncommon compared to other types of cancers. It is not a curable cancer, but it is a very treatable cancer. And over the years, survival times with myeloma have greatly increased, and now is a matter of years that people live with this disease. It's more common in men than women, and it also tends to be more common in the African American population. Most patients are older, 65 to 75-year-old range, and only a small number of cases are familial, that is, transmitted from one family member to another. Most patients present with a variety of symptoms. The most common symptoms that we look at are things related to an elevated calcium level, kidney failure, anemia, and bone pain. And that makes up an acronym we call CRAB, with the C being for calcium, the R for renal insufficiency, the A for anemia, and the B for bones. And so that's an old kind of word that we sort of remember in hematology when we're thinking about, could this patient have multiple myeloma? Typically, the diagnosis is made on a bone marrow biopsy, which would show an excess of these abnormal plasma cells that we talked about. And then you combine that with the results of blood tests, urine tests, and a variety of x-rays of the bones to sort of put that together to make the diagnosis. Well, first the patient undergoes a workup, including the bone marrow biopsy and the blood and urine tests, as well as the x-rays of the bones, and those kinds of things help us to decide what the best pathway would be for the patient. Most patients are considered for a stem cell transplant. That's still the probable single best treatment for multiple myeloma. Typically what we do is we give patients a 3-drug combination to get them into remission. And then once they're in remission, they're referred to a bone marrow or stem cell transplant center. And then after they've completed their stem cell transplant and recovered from that, they are typically put on some type of maintenance therapy to help them maintain the remission that they've achieved. Multiple myeloma is staged a little bit uniquely compared to other types of cancers. There are only 3 stages, stage 1, 2, and 3, and it's based on blood tests and molecular testing from the bone marrow sample. We treat patients pretty much the same regardless of their stage, and the staging is really more used for stratifying patients into high and low risk and for research studies. Most of the new stuff is centering around what we call CAR T-cell therapy, which is chimeric antigen receptor T-cell therapy, where a patient's T-cells are being engineered and then transfused back into the patient to try to attack the cancer. This is a very technically challenging type of treatment. It's not a treatment that's done in smaller communities, but typically at bigger hospitals, and certainly showing a lot of promise in terms of trying to control multiple myeloma. And then the other type of treatment is what we call antibody drug conjugates, which are antibody drugs that target an antigen on the plasma cell, and they are attached to a chemotherapeutic type medicine with the idea of having a more targeted chemotherapy to the myeloma cell rather than giving something that just goes everywhere throughout the body and attacks good cells and bad cells. So these are things that are now FDA approved. They're basically for patients who have exhausted their other resources in terms of treating myeloma, but certainly coming to the forefront in management. With most chemotherapeutic regimens, there are a variety of side effects that we deal with in treating multiple myeloma. Certainly concerns for infections, suppression of the blood counts, need for blood transfusions, management of pain and so forth. But probably the biggest side effect that we deal with in multiple myeloma is neuropathy. It's a common side effect of most all of the drugs that we use to treat multiple myeloma. And it's difficult in that there's not a good way to measure how bad somebody's neuropathy really is. So it's a subjective complaint. In terms of treating the neuropathy, there are a variety of medications that can be used. Gabapentin, Cymbalta, and a variety of other pain medications and so forth. But it's a very troubling symptom that patients have, and it is difficult to manage and difficult to treat because of the subjective nature of it. So a stem cell transplant is basically a way of giving very high doses of chemotherapy to a patient. What we've learned is that with multiple myeloma, if you can give multiple drugs and if you can give drugs at very high doses, you have a higher chance of eradicating the myeloma. And so the idea behind the stem cell transplant is to give a very high dose of chemotherapy to totally wipe out the bone marrow and hopefully wipe out as much myeloma as you possibly can. And when you do that, a patient generally would not be able to recover and to have their bone marrow start making normal cells again. So the process is the patient's given a white blood cell growth factor shot over a couple of days, and that raises their white blood cell count very high and pushes these stem cells or these immature white blood cells into the circulation. Those are then collected off of a machine and frozen, and then you subsequently will get your very high dose of chemotherapy to wipe out the bone marrow. And then the following day, those stem cells are transfused back into you through an IV, and they know how to go back to the bone marrow and repopulate the bone marrow so that you can survive and have white blood cells again and so forth. I always think it's important for patients to educate themselves, and there's a variety of ways of getting information about myeloma. Certainly having a sit-down conversation one-on-one with your physician is the best way to start. But if you want to look into information on your own and you like to use the internet, two of the better websites are the American Society of Clinical Oncology's website, which is cancer.net. And then the National Cancer Institute also has an excellent website for all malignancies, and that is nih.gov. That's the National Institute of Health. And then you just find the National Cancer Institute and click on that, and it'll take you to a variety of malignancies that have very well written information and very reliable information.